Great to see folk on the call. We've got 3 presentations to get through, so we're going to go straight into Brad and Charlie, who I can see on the screen, giving us an update on the HCAI in SIM 30-day report out. So thank you. Over to you.
Good afternoon. My name is Charlie. I'm one of the matrons in infection prevention and one of the process owners for the RPIW on the ongoing work.
And I'm Brad, matron in SIM, the other process owner for this piece of work that we've done.
So just in terms of how the RPIW came about, we know as an organisation we've had a challenging year, like many organisations nationally as well, in terms of HCAI. Reducing HCAI is one of the annual commitments. Our way of investigating HCAI is to have an RCA. And with the introduction of PSIRF, it gave us a unique opportunity to create a new process which eliminates waste. The RCA process has worked. It's obviously time now for us to implement the PSIRF and to move away from areas that don't add value and focus on learning for improvement rather than reporting for assurance. So the purpose of the RPIW, which was I think it was the week of the 15th of January, was to reduce the time taken to identify, share and act on learning from HCAI incidents, reduce the non-value added of the investigation process, and we'll be able to demonstrate how we've been able to do that. Increase the patient, this is crucial, increase the patient and family participation in the investigation of the HCAI, and increase the learning and the breadth of learning from incidents and being able to share that much quicker. So these were the documents from the beginning of the week and the end of the week. It's just as a recap. So the first one, the percentage load chart, we can see that there was a large increase of work on the nursing side in terms of investigating an RCA, completing the documentation. At the end of the week, it's much more evenly distributed. We've moved to a model, a dyad model, so the workload is distributed evenly between the medical and the nursing team. The bottom slide, and as we shared at the report out at the end of the RPIW, that slide shows the process map for one RCA alone, and that was just for one. And so we were able to, by the end of the week, streamline the process to as it is shown on the slide. So just as a recap in terms of how it's changed, what the outcome was, there will be no more retrospective RCA investigations, no more long waits for an RCA meeting, and as we call it, there are times we have to make the meeting. It might take a few weeks, and that's all lost time for learning. And no more solo nurse-led investigations, as in that it's not the nurse and the ward manager or the band 6 on the ward that leads on the investigation.
Thanks, Charlie. So on the back of that, we came up with a new process, which is sort of shown in the flow chart to the right of the screen. And as Charlie sort of already said, the most important bit, that it highlights that at each stage of the investigation, there's a conversation and an update with family and the patient being at the centre of what we found, what we're doing about it, and an update on their care in real time. So as well as getting the information to the ward teams, it's also updating the patients in real time rather than having to wait for that duty of candour process that has quite a delay, as we found from the week. We've also introduced a new action forum and looking at restructuring our previous existing infection control meetings to have more of a focus on action and looking at themes and trends of investigations to look at what we can do about it, but at the same time having that discussion and bridging that balance between improvement and assurance that we discussed at the initial report out. We've also introduced a new escalation clinic. This is the opportunity for staff to take any queries or questions that they have or any uncertainties, and make sure that we still have that involvement from the specialist teams of IPC and microbiology to give that assurance that we're not missing things and it's not just becoming a free spirit off on its own, even though we are speeding up the process. It's probably important to note at this point that the process that we came up with in the week is still very much the same process that we're using and is working. We've made some minor adjustments, but on the whole, the flow of what we said we were going to do is what we're doing, and it is working in practice. So we've trialled so far over the 6 older adult care wards in SIM. We're looking in the next week or so to roll it out to more of SIM, looking at our medical wards and maybe the admission wards. We're also in discussion with cardiorespiratory and hoping to roll it out and trial in cardiology towards the end of March, once we've got some engagement and done some work on involvement with their teams. We're also working quite closely with the risk management team to try and digitalise some of the documentation and processes that we've done. Through some PDSA cycles, we're nearly there with that, which will open up some more opportunities to theme and look at trends rather than just individual cases, which will help with our learning and actions from future investigations. This is a slide showing our sort of data and metrics that we measured as our baseline and where we're at today. So the overall aim of what we're trying to achieve is reduce the number of healthcare associated infections. To date, we haven't seen a statistical significant drop in the number yet. Not overly too much of a shock. It's still very early days, and to get those actions and learning and change the practice on the ward areas as a result of this is going to take some time, but we're hopeful by the 60 and 90-day report out that we should see that come down. We've had some really good improvement on the lead time from sharing of learning. We think that the old investigation took towards 99 days to turn around an investigation. With the ones that we've done to date, we think we've got that around to 12 days. There are some delays with that. Some are taking longer, but we're attributing that to the backlog of work of the old process. So the hope is once more investigations are using the new process, that should again further speed up. Our morale metrics around are the right people involved and the work being shared evenly from our teams on the ward are probably our biggest success to date, with all the staff that we've surveyed as part of this 30-day report out saying that they feel that the right people are involved and the work has been more fairly shared. It is a smaller sample size than originally, and we are going to sort of build that up over the next 30 days. Just to make sure that still is the case. And our documentation using the 5S model, we have improved, we acknowledge that. We don't quite think we've met level 2 yet, but the hope is with our digitalisation over the next 30 days that we should see that improvement as well. 11 investigations have been investigated under this process to date, with the initial investigation taking 20 to 30 minutes by our clinical and nursing teams on the wards, and on average 48 hours for the learning and action plan of these investigations to be shared with the clinical teams and the patient in a verbal sense. This is excluding the sort of duty of candour letter process that follows on from the investigation. A really good example of how this is working in practice was from one of our trial wards, was where the notification came into the ward. Within an hour, the ward team completed their investigation, identified that there was potentially a missed opportunity to treat a UTI and some gaps in reporting of antibiotic sensitivities. A discussion with microbiology on the day initiated some change, and within 24 hours of that notification, the way in which the microbiology team released their information has changed. So it's a really good example that we can get results out of this process really quickly.
So our next steps for the next 30 days are a focus on education and prevention of HCAI with patient involvement. And throughout the week, well, at the beginning of the week and all through the week, it was very patient centred, and we know that we need to start with the patient in terms of helping to support them with how they know that they can help keep themselves safe whilst in hospital. And it was on the action log for one of the actions out with the RPIW week. So myself and Sue, the ward manager on J17, will be looking at that. As Brad has said, we're scaling up to the rest of SIM and further expansion of the trial to cardiorespiratory. We had a very positive meeting. We're very grateful for cardiorespiratory for meeting with us yesterday to look at starting the process and scaling up of the escalation clinic. It's still very much in its early days. It's very new, and we still need to work through what they look like. But
within SIM, we're continuing to work on our action forum and how that looks, and getting the whole MDT team involvement within that. Looking at our existing CSU meetings and how we can refocus that to initiating change and learning. And there's also some conversations in the background about the level of harm attributed to some of the infections we investigate, and the requirement for duty of candour in a written form and we're working through some issues with the teams that who investigates and where the infections are attributed to and what teams are responsible. I think that is us.
So thank you very much.
Thank you. Fantastic, Brad and Charlie. Really great work and really powerful direct patient impact in terms of speaking to one of our annual commitments. So always round, really good. So we will keep going and save questions for the end, as we normally do. So I'm sure there'll be lots to come back to in that one. But let's go on to improving team induction satisfaction. Kate, thank you. Over to you.
Hi everyone, my name's Kate Frost and I'm a Senior Project Manager in DIT, and I'm just here to report out on the improvement project I undertook as part of the LIMS course. So I joined LTHT a year ago and I'd undertaken a lot of QI training before in other trusts and other roles, but I wanted to really learn about QI in this trust, so I signed up to the LIM course. It fits really well with the role of being a project manager. My team had also really good positive experience about the course, so I was really intrigued to do it. And then through the LIM course, you have to think of something to improve. So I was new to the trust, actually new into a DIT team, and I kind of struggled about what my problem or challenge could be, seeing as, you know, you don't want to be that one person that comes in and says, we need to change this immediately and all of that. I'm just looking at Paul there. So I tried to think about something that I'd had experience of, and that was also pertinent to our team, DIT as well. So I wanted to look at the standard local induction for the projects and programme team. I'd kind of settled on that challenge because I'd walked through the process and I could see some key improvements to make to ensure that people joining the project and programme team felt confidently inducted, but also felt part of the wider DIT CSU. So in LIM language, there were two key wastages. The key one really being that the induction process was over-processed, as each line manager was kind of looking at this as a task to design for each new team member, rather than having something standardised and effective, which covers all the aspects of the rest of the department. And then the other key wastage was waiting. So often we'd have to be waiting to get information from other really busy key departments to learn about their work as well. So once I decided on this, I brought it up with my line manager and other new members to the projects and programme team to understand if there was an actual process we needed to improve. And it was overwhelmingly agreed with, really, that this was something that the team had wanted to do, but just hadn't really got that kind of headspace and time to do it. So in terms of the tools that I used to kind of understand what to do next, like I said, I'd done the induction, so I'd had that chance to do a Gemba walk, and meant that I had a really good understanding of the problem. I did try to use some other tools like the spaghetti diagram, but it just wasn't applicable for this type of improvement. We weren't walking around a ward, etc. But I did a process flowchart, which is this colourful block here, which was really useful to see the amount of action needed by different members of the team to get this done, and highlighted some key areas of wastage. So then I decided the next step really was then to engage the rest of the team. And decided to kind of help that, I developed a survey. I raised this at our team meeting, and it was sent to anyone who had started in the team in the last 12 months to measure how they'd found the induction process, what their highlights were, and what they thought could be areas of improvement. The survey also asked staff to rate from 1 to 5 the key outcomes that our management team would have wanted a new recruit to receive from the induction, so that we had something measurable to go against, because obviously this is a bit qualitative and a bit opinion based, but we tried to put some metrics in there. And then using the outcomes from this survey, I was able to target areas in need of most improvement. We developed a bit of a checklist for just programmes and projects team. So we have a DIT one, but we wanted one just for our team, to ensure that commonality across the team, but all the key links to documents in one place, etc. And that's what this kind of box is on this side are. And a key thing that people have fed back on was that they wanted to know what other teams did and develop those connections with other teams in DIT. We've got a lot of teams. So we decided that we would film some intro calls, just to reduce kind of the kind of demand on other heads of teams, etc., get them to record a video about what they do and what their team does, how we can engage with them, all of those kind of things. And to be a bit of a less burden on that, we've actually asked our most recent new starter, who's in this picture on the top right hand corner, to have those as part of her induction and record them, so that we get a video library that we can use with future starters. And then finally, we've pulled together a bit of a shared folder which anyone in the team can add new bits of information to, documents, links, which will be useful, helping to spread the ownership of this across the team and making sure that we're continually improving the process as so many things change. We don't have any metrics to show the improvement right now. So Miyuko is our first new starter to the team since we developed this. So she hasn't actually finished her induction yet, but we've got some points here. So one from management and one from Miyuko about having that clear plan and feeling really supported in post. So I'm quite confident that once we've had the new starter through, we can use the same survey and hopefully see an improvement in the metrics from that. So what went well? I got a really high level of interest from our team to do this, along with the fellow new starters being really honest about their views on their induction and wanting to participate in a workshop to support the next steps. There was also buy-in from our management team and trust for me to get on with this based on the opinions of the team rather than what they thought should be done. And through doing the videos, lots of other parts of DIT are keen to have access to these. And actually, separately, our comms lead is looking at how they can incorporate these into something bigger for the team. And I think I've not actually highlighted it here, but I think involving our current new starter in creating and leading these videos has been really good and has made them feel like they're contributing to the team already, even though being very new in post. So what would I do differently? Hopefully this is going to be a continual thing that we do. So I have been thinking about what would we do if we were differently. And the key thing is that this can take a lot of time, much longer than I anticipated actually, partially because we're in a lull of new team members, but also because these things can quite easily slip down a list to do when we've got a lot of other priorities and deliverables to achieve. So I think, I would make a lot more time for this and spread this a bit wider across the team, involving the rest of our DIT colleagues a lot sooner, so giving them more time as well. And I think that spreading as well would help you not become the new starter person in the team. It's definitely about the ownership across the team. And hopefully, as we continually improve this, we'll improve on that joint responsibility across the team. Thank you.
Great, thanks, Kate. Again, brilliant. I mean, speaks to how we think about looking after our people, our first impressions when people join the organisation, making people feel welcome and actually making our culture, our values a lived experience for people rather than something we just talk about. So really great to hear that. Well done. Brilliant work. Okay, so we'll keep moving if we may. So Helen, I can see you're on improving referral time in occupational therapy. So we'll come straight across to you, please.
Thank you. Hi everyone, I'm Helen Stebbins. I'm an occupational therapist and therapy lead for Patient Flow, and I'm presenting just briefly about the project for my LIM course. So it might be worth just explaining briefly what a CCB is for those that don't know. So a CCB, or community care bed, is part of the pathway to discharge. So for those patients whose needs can't currently be met at home with community support because they need a little bit of rehab, recovery and reablement and time to undergo the Care Act assessment if need be. So the current process for referral into a CCB is largely done, determined by a physio assessment and discussion with the family and the carer. Occupational therapists aren't routinely involved. And we know as a system that we refer too many people into CCBs that needs could be met at home, and this has all come about based on the Home First work that's been going on. There's lots of data to support that. So what I wanted to do was to understand if we had occupational therapy involvement, would that potentially reduce the number of referrals on L34 to a CCB? So how did we test this out? So we did a small test of change on L34 where we looked at the referral criteria into occupational therapy, and we agreed that to test this out we needed to change that criteria so that we would start accepting people who've been referred for a CCB onto our caseload. But we also looked at accepting people on much earlier into their discharge and admission journey, so that we'd start assessing them when they were assistance to with a wheel Zimmer frame, day one after operation, so much earlier on in the journey, to see if we could change that discharge destination round. So to do that, we did a lot of education around the benefits of early intervention, about joint working and linking up with the MDT, and we did a lot of sessions with the physios and the ward staff to try and embed that ethos on the ward to share and promote joint decision making. So our outcomes, we found that the OTs, on top of the caseload that they already had before this test of change, we picked up 13 additional patients, 13 patients who were initially planned following physio assessment for CCB referral. Following OT assessment, 7 of those patients went home with community support. We feel that that reduced the number of referrals to CCB, and it's perceived as a better outcome for the patient because they're going home to their own environment. There's less risk of them becoming deconditioned, less risk of hospital-acquired infections. They're able to engage in the usual routines and their occupations, and they can continue to engage with their social network because they're in the normal place of residency. So we felt that were really, really positive. The OT team involved reported feeling in control of their workload because they were taking ownership for screening the referrals. They weren't waiting for the ward or the discharge teams to put those referrals in so they could better manage their caseloads. They also found that quite often a patient's discharge destination gets changed from CCB to home because of the length of time they're waiting for transfer to a CCB. So then it's almost like a panicked assessment, last minute rushed, because they know that person's medically fit and ready to leave the hospital, whereas this allowed the OTs to provide proactive intervention, which were really positive. We did find, though, that it caused a bit of confusion and conflict because a lot of patients and the relatives like the idea that the mum and dad are going to a CCB because it's perceived as a safe place to go. It's going to reduce potential risk. So the OT had to do a bit of backpedaling, if you like, to try and unpick those conversations and say, no, your mum and dad's needs the best met at home, and this is the support that we can offer in their own environment. So it did lead to a few tricky conversations, and obviously that took away from the OTs sort of completing the clinical times, their assessments and things like that. We found that this increase the OT's workload dramatically, and there's a mismatch between capacity and demand, and especially when we're entered into silver, it weren't possible for OTs to prioritise people who were going to CCBs. So we felt that were a missed opportunity really, and probably did lead to people going to a CCB when actually they didn't need to. So we're rolling this out now on the No Reason to Reside wards at Beckett Wing, just to see what it looks like and if it has the same impact for a different cohort of patients. So the people at Beckett Wing, they tend to have quite complex needs, otherwise they'd have been discharged and not go over onto them wards. And then I want to explore the missed opportunity to see if there's any ways that we could be working a bit differently to ensure we are picking them patients up. And I want to share the information with Christine Beck, the head of OT. Thank you.
Fantastic. Thanks, Helen. Again, great work. Such an important part of our care pathways for patients, and something we know we've had such a challenge over the years around getting people to the right decision points and the right level of care after their acute hospital stay. So really important that we get this right. So great work. Good to hear progress on that and how we can take that all forward. Okay, look, we've had 3 really, really good presentations, so we're officially at time, but I'm sure we've got time for some Q&A, because it's for all of those 3. They've really not just shown the great work going on with application of the Leeds improvement method and your own training in that for those who presented, but speaking really strongly to some of our annual commitments for this year. So let's open it out for comments or questions from anybody. Gillian.
Oh, thank you ever so much, everybody. That was absolutely brilliant. I'm loving the video library concept. I know that was in relation to induction and in terms of that, making sure that somebody doesn't feel like they're the newbie and everything. But actually, I think that video library concept could be used in so many of the actual presentations that we've just made here, including the last bit, around occupational therapists. So I'm sure there will be something around that video library you were mentioning there, Helen, around your ability to do everything to everybody everywhere when things move into Silver Command. And I just think I just loved the idea that having conversations with people about the role when they do it and the improvement would help people know who to go to and when.
Great, thanks, Gillian. Helen, particularly for you, but actually also I think for Brad and Charlie, but what sense did you have of how, for both of these areas, for both the presentations you've talked about, there can be a sense that the kind of frontline ward staff aren't really owning some of these issues and feel a bit disconnected from them. So for both of you, I'm interested in how your work has had a sense of getting that connectivity and engagement of staff. I don't know who wants to kick off.
We can go. I think from my view, I think that with our old process, the HCAI process, there was quite a lot of frustration with the process and the delays within that. And I think that the new process and speeding things up and sharing that workload has sort of reignited the interest and sort of the focus on this. So I think it has engaged staff on the wards that we've trialled it on so far from us.
And also the vision was that anybody could attend that post-infection review as well. So when that post-infection review occurs on the ward, whoever, we want obviously the medical team and the nursing team, but if it was a CSW or a student nurse or a student doctor, everybody was available to attend and see where the investigation process and learning.
That's really encouraging, I think, because it's one of those areas where at times it can feel as if it's somebody else's role to do something, but actually this is one where we've all got such an important part to play to get this right. So that's really good to hear. Helen, anything from your side? Any thoughts?
I think we were super lucky on L34 because Becky, the matron, and Katie were so invested in getting it right, and because they're really dedicated to sort of the reconditioning the nation and the pyjama paralysis, it played really nicely into that. So we were lucky. They were bringing it up in the perfect ward meetings and things like that. So I was super impressed.
That's good to hear. I mean, I guess if feeding it into things like perfect ward does give us some lessons and thoughts of learning for elsewhere in the organisation, doesn't it? So that's also really, really good to hear. Okay, so I can't see anybody else wanting to come in. Apologies. So if there is anybody with their hand up, do shout out now, because I can't see any other hands. But otherwise, 3 really brilliant different areas of presentation in areas of our organisation that are really important for our patients one way or another, and really important for our staff. So I think fantastic. Thank you again to Brad and Charlie, to Kate and to Helen. Well done with the work. Let's keep that going, and we'll look forward to, particularly for the HCAI, we'll look forward to hearing from you in a few weeks' time when you're back for your 60 days. So otherwise, thanks very much, everybody. That's the end of today's report out.